All right, well, let's get going. It is 5 past the hour. It is officially match day, so congratulations for all the new students who have now matched into the great profession of general surgery. We've got our poll coming up, so it looks like pretty well established hernia surgeons here, Dr. Kastenmeier. 5 to 25 and 25 to 100 are kind of our nice two ranges.
Good.
So with that being said, let's get started. My name is Joshua Dilday, and welcome to the How I Did It series from the American College of Surgeons Resident Associate Fellow Committee. This is put on by the Associate Fellow Committee, so we are very honored to be doing this case series and on how I did it. And we couldn't pick a better topic today with complex hernia. It's a topic that we felt recommended a broad variety of surgeons. It's something we see every day whether we want to see it or not. It can be either that which excites us. It could also be the bane of our existence. There's so many different complex feelings and emotions that can come with all of these complex hernias. So we are honored today to have the great Dr. Andrew Kastenmeier joining us. Now, Dr. Kastenmeier joined us. He has a initial medical background. He did his initial training in med school at University of Madison. He left the state of Wisconsin to go do residency at University of Utah, and then continued going farther west to do his fellowship in minimally invasive surgery at Legacy Health in Portland, Oregon. And then he came back to the Midwest at the Medical College of Wisconsin, where he is now. He is currently an associate professor of surgery, and not only that, he's also the chief of the Division of Education. He's director of our fellowship here at Advanced GI and MIS for the Bariatric Fellowship. And he's associate professor in the Division of Minimally Invasive Gastrointestinal Surgery at the Medical College of Wisconsin. So, Dr. Andrew Kastenmeier, and all of that, thank you so much for being a wonderful personal colleague and mentor of mine. And we look forward to getting into this wonderful conversation on hernias. Some quick kind of housekeeping rules. So, with the webinar, we do have the option to do and entertain questions in real time. So, most of the questions, this presentation will be kind of case based. Dr. Kastenmeier and I will have a nice discussion over some of these difficult conversations, difficult cases, difficult hernias. Feel free for those in attendance to ask questions in the chat, and then we can get to those questions in real time, but we'll try to get to most of them at the end. And this is going to be very discussion based. We'd love to hear to be able to answer those personalized questions. For those not in attendance, that is going to be recorded. It's going to be put on likely the ACSRES YouTube channel, and that'll be recorded after kind of the video is done at a later date. So we welcome those who aren't able to be with us live, but we look forward to you being able to watch. So the nice thing about this conference, we'll get started here soon. It's things that we want to really hit today. Not every hernia is straightforward. I know that. Dr. Kastenmeier and I were just talking about a complex one I had earlier today. Not all these hernias come nice tied up in a bow. So we want to talk about some preoperative considerations, and not just the normal preoperative considerations that we've all learned early in our training, but some nuanced things that a fellowship trained surgeon and an expert in the field is going to help us with. Some operative approaches. There's a variety of different ways we can approach these, and we'll go through some adjunct procedures. Mesh considerations. You can't have a hernia discussion without mesh. And of course, fixation considerations for a variety of different hernias. So without further ado, I will stop talking and hand over the reins to Dr. Kastenmeier. Thank you so much, and let's get going here.
Thanks for the intro, Dr. Dilday. Appreciate it. Just a quick note, this moving truck is actually a moving company in the city of Milwaukee. They did my last move when I moved out of an apartment to a house here in Milwaukee. And I gave my card to all the guys that moved, and I haven't heard from any of them, so they must be doing some good lifting technique. Just a couple of disclosures here. Gore, I do some teaching and education for, and that is nothing in sales or anything like that. The teaching and education is really, I help their representatives understand from a surgeon's side what some of these approaches are, and where we put the mesh and what we're looking for. And so it's just teaching and education. And then Covidian, we do some research and some of their hold some databases for them, and I'm not paid through that at all. We have a research team that helps organize that. Just a few things to know before we jump into some cases. I think it's really important that there's there's multiple appropriate ways to fix a lot of these hernias. And I think the more methods that you know, the better you can optimize these cases to specific patient medical problems or patient preferences. Um, and you can take into account some of the comorbid conditions and try and minimize the risks by using different techniques. So the point being, with hernias, it's not always the biggest, most most durable one that you're looking for. Sometimes you gotta do something a little bit smaller to try and get a patient through it. So, and many of the topics that we discuss don't have right answers, but hopefully, in the context of the specific cases, Josh and I can talk about some offshoot questions about that you can apply to a variety of different hernia cases that you might encounter. So should we dive in, Josh? Is that
I,
all right?
I think so. Yeah, that's great. So let's get started with the case. I don't think there's a better way than let's talk about the real life scenario.
Sounds good.
So we'll challenge you with this case, and we'll see kind of how you did this and
Sure.
what your thoughts on. So, 62-year-old male, of course, recent history of complicated diverticulitis, managed with exploratory laparotomy and lavage. So we already know kind of set up for an emergent case. Of course, developed recurrent perforation, multiple X-laps, and eventually they had to do a loop transverse colostomy. So we kind of know where this is going. Then, of course, developed a wound infection and a dehiscence is the bane of every acute care surgeon's existence. Eventually required a skin graft. So now, of course, the buck is now passed to you. He's a year out, has a giant ventral hernia, skin graft on top of that. The loop colostomy is there, and he still has a sigmoid colon. And we've got a picture here on the next slide. This comes in. Now, luckily, it's not in the ER, but it's in the clinic. So what do you do when you have this patient combined with this scan? And I'll actually have you kind of walk us through some considerations that you're seeing on the scan, and then we can dive in and see what you would do with this.
Um, what you see here, just some cuts from different levels, and you can see a pretty wide gap there. The second picture shows that transverse colostomy coming out the right side of his abdomen, and then a little bit lower, you can really see the retraction of the abdominal wall and how the hernia sac hits that skin graft over top. If you measure, especially on the center one and the far right one, where it gets really wide, it's about 20 centimeters across there. So I think, this is a pretty tough case, but and actually I'm doing this one this week Wednesday, so we'll see how it goes. Maybe I'll get some good hints here from you guys today. But the I think the issue is a couple of things first. One is making sure that he's optimized pre-op, and we'll go through a few things that we look for there. And then the second is really the hernia repair is going to be the secondary operation in this particular case. So really the primary goal is going to be getting his sigmoid out and then potentially taking down the stoma plus or minus a diverting loop. And so when you're in a combined procedures, what are the considerations about what you will and won't do in a hernia repair? So I think, for the pre-op optimization, a few main things. So smoking cessation, I think is critical. And my approach to smoking cessation is this. When you've got something big and complex, it's going to be a big operation, some contamination. You might be doing some myofascial releases, component separation, stuff that you can only do once. Those are the cases where I say we can't move forward without smoking cessation. Now, if I'm doing a small umbo or an inguinal hernia repair and they're smoking, it's not ideal, but I generally don't hold them to smoking cessation before I'll offer them an operation. But when we've got somebody where we're doing stuff that you can only do once and they have a lot of risk factors for complications, that's when I say you got to do it. And the way I do it is I tell them to call uh, once they've had their smoking cessation date. And then I'll schedule it for about 4 to 6 weeks out from there. And then I'll do pre-op testing about 2 weeks beforehand, and then the day of surgery as well, with the possibility of canceling if if they're back on.
Now, sir, what pre-op testing do you do? I know we've seen that in the plastic surgery team will do that a lot, sometimes controversial. And have you ever had where the patients have refused to do pre-op testing, and how do you manage that?
Yeah, no one has refused it, but they'll certainly debate the results of it, especially because there's an equivocal range on the on the testing. So um, I think, and it, I would say most of the people by the time we get there the day of, we're good because we've established at the pre-op appointment a week or two beforehand the testing, and they're tested there, and they know they're going to get tested again. And so, um, in some cases, I won't hold them to total um, tobacco cessation. Like I'll let them do nicotine gum or something like that. But in these bigger ones, we'll try and get no smoking and no tobacco use whatsoever, on these bigger ones where we've got one real shot at it.
Yeah.
Um, the other is going to be glycemic control. So uh, a little bit of data in the hernia literature and a bit more in the orthopedic literature that if you can get their glycohemoglobin below 8, that you can reduce infectious complications postoperatively, wound morbidity. And so we hold, especially our patients where we're doing, again, a bigger case, um, potential contamination, might be doing some myofascial releases. We'll hold them to getting appropriate glycemic control. We'll work with an endocrine, our endocrine colleagues, or with their primary care to try and get them to that point. Nutrition, so making sure that if somebody's been in the ICU because they were a gunshot wound, their nutrition, you want to get them out and healed from all that and back to at least a decent level of nutrition. Same with wounds. They got to have their wounds. A guy like this, they have to be closed and healed. No more infection, no more drains in place when you're going to tackle the complex hernia repair.
Okay, so that's so you've got the pre-op. So, of course, this is an acute care surgery patient. So some of that's kind of a luxury at the time, but now he's in your clinic. You've talked about all of these things: smoking cessation, glycemic control, nutrition. And then for this one, so just kind of going back, we've got this loop colostomy that's in the way. It looks like, would you say he has loss of domain, or how would you classify these fascial edges? You said they were broad.
Yeah, I think so. This third picture is him laying flat on his back, relaxed, and even with a wide defect, it won't all the way go back in. And when I get him on the table, I can't push it below the level of his fascia. Um, so his domain is compromised there. He doesn't have, when he's standing up, most of it is out, but at least part of it goes back in. So um, and then the defect is pretty wide at 20 centimeters, with quite a bit of retraction of his abdominal wall. So in this one, this is, there's not strict criteria for this, but in this one, I did pre-op Botox in preparation. And so what that is I have our PM&R guys under ultrasound guidance inject Botox into the lateral abdominal wall to try and relax those muscles. And we do it between 2 and 4 weeks before the operation. And that's to try and give us as much pull on that abdominal wall as we can. Um, that there's still, I would say, not great literature about it. So it's not totally certain, but it's a pretty low risk um, a low risk procedure preoperatively in a pretty complex patient to try and give yourself every little advantage that you can. Um, it does get denied and can be expensive to inject Botox, so
Okay.
that adds to some of the negative to it, but pretty low risk, easy for the patient to do. It took a while for us to set it up with PM&R and radiology because they have the privileging for these Botox injections. Um, but I think, and the literature will tell you, you know, there's there's some decent literature that you can, for example, in a medium size, avoid a component separation and still get it together
Hmm.
without doing myofascial releases. So I tend to use it in the worst cases to try and get me every little advantage when we have a really big gap there.
Now, does that distort the anatomy? I know sometimes for our foregut stuff, sometimes those Botox injections routinely can sometimes make things worse or more scarred in. Do you have that if you're doing this one time, 2 to 4 weeks out, plain distortion, burn any bridge, scarring, or anything like that?
Yeah, I haven't encountered no reports in the literature of that. They
Yeah,
do it in the lateral abdominal wall, and they inject usually three different spots on each side, about 50 units spread throughout the three layers there in three different spots. So 50 units in each of three spots. So 150 units on each side of the abdomen. And it's out lateral enough that even if I'm doing a myofascial release, either a transversus abdominis release or external oblique. I'm not in those planes that far lateral anyway. So yeah, it hasn't been an issue that I've noticed or that's reported in the literature for this.
okay. So he's been optimally controlled. He's got his Botox. So operatively, how would you approach this?
So I think in this guy, my plan is this. So his primary operation here is going to be a sigmoid colectomy, take down of the transverse colostomy, and then plus minus a diverting loop ileostomy.
Hmm.
And when I approach that, the hernia repair, I think there's some cases where you can say, go get your other operation and we'll do the hernia repair after. I
Sure.
think in this case, that's not really going to be an option. He's going to have that skin graft opened up. Um, and we got to do something to close his abdominal wall more securely than just covering that skin graft back over top of it. So despite the fact that we got to do something, I tend to lean on the more conservative side. So when we have non-optimized conditions, I tend to not want to do procedures that can only be done once.
Okay.
So meaning, he's gonna have a colocolostomy, anastomosis. He's gonna have a second one of those, and maybe a loop ileostomy. Um, and so we're in contaminated conditions now, and possibility of a leak, a wound infection, all that sort of stuff. So we're not in optimized conditions. So I got to decide, am I going to try and give him the most durable repair and burn every bridge that I've got, take down the posterior rectus sheath, do an external oblique or a TAR, try and get them together, put a piece of mesh in? Or do I do a lesser procedure that doesn't burn any bridges and knowing that there's a really good chance that or 100% chance that he's going to have to come back for a hernia repair down the road? And my thinking is this is I mean, it's a pretty big, difficult colon operation with a couple anastomoses. I think there's a pretty high likelihood that the colorectal surgeon I'm working with is going to want to use uh, a loop ileostomy. So my goal here is I'm going to try and close this without doing any myofascial releases. And if that means closing primarily, I don't think I'll be able to do that because the gap is so wide. Then I'll bridge it with some sort of absorbable mesh. and commit him to a second operation for the hernia repair under ideal conditions. And I think, Josh, this is where you'll probably encounter people who would say, I'd go for broke on this one. You know,
Sure.
I'd get in the retrorectus space. I would do myofascial releases to get it together, and then I'd put a piece of mesh in there, um, in the retrorectus space in a contaminated case, and try and get this guy through in one operation. Um, I think, in my eyes, I felt like with two anastomoses and then putting a diverting loop, with a hernia this size, I prepped him for, hey, you're going to probably have a second operation for a more definitive hernia repair, and I don't want to burn any bridges at this particular operation.
So you're kind of doing the do what fails well technique instead of, swinging for the fences. Now, with his case, he's got the ostomy there and the skin graft. Which one complement or complicates your approach more?
I think the stoma I can deal with. I can, if he ends up with a diverting loop, I can work around that. That's going to be fine. The skin graft, um, I mean, you look here. I mean, part of the problem is going to be getting his abdominal wall myofascial muscles together. But then there's this possibility of not being able to bring that skin together at the midline. And so, I'm worried about, if I cut this out, am I going to be able to bring the skin together? And certainly if you don't cut it out and you've dissected all of that viscera off the underside, is that skin graft just going to die off at that point, right? So I'm pretty committed to taking this out. If we can't get his skin together, then what I'd do is probably vac his skin, and then I'd call plastics,
Okay.
and we'd talk about getting coverage on there, temporary coverage, um, from there.
Now, before you kind of show us kind of the schematic in terms of what exactly you're going to do, and we've got a couple questions, but
Yeah,
one, you already mentioned that there's a high likelihood there's going to be a diverting ostomy because we're going to have two anastomoses. How we have a question about kind of where that comes into play. How is that going to be either planned for if you have a high likelihood of knowing you're not going to get reapproximation primarily, may not go for broke with the release? And how is that thing going to be planned, especially if you may have to come back and do another operation?
yeah. I think that gets into, this idea. We could talk a little about, putting mesh in a clean contaminated or contaminated case. And, I think there's some literature out there that says, yeah, you can do that. And, but I'd also say that not every, the CDC classification system of contamination 2, 3, 4, within each of those subgroups, it doesn't quite capture everything that you got to deal with. So, a little colocutaneous fistula off on the side or a little stitch abscess that's infected, those are dirty, but that's way different than like a small bowel where you can see the mucosa sticking out of the midline type of a fistula. Um, so I think, when they're bringing up a loop ileostomy, yeah, it's contaminated or clean contaminated, so you could put a lightweight polypropylene in, but that ostomy has to come down, right? And so if you've put some macroporous polypropylene circling that stoma, you've made that takedown potentially pretty difficult. And so I think part of it is not buggering up or making more difficult that part of the operation. The other is I wouldn't want to put a permanent piece of mesh as a bridge here for a couple of reasons. One is I'm going to be coming back, and we know that that's going to be horrendous to chip the viscera off of it. The other is that we're talking about a contaminated case, which, yes, you can use, there's some literature showing you can use macroporous polypropylene, but in my mind, you can use it when you've got it in a space that has well vascularized tissue that
Sure.
will allow for the body to promote bacterial clearance from it in this clean contaminated or contaminated situation. So that means in the retrorectus space for me.
Okay.
If you're using it as a bridge, you basically got omentum and viscera on one side, subcutaneous tissue on the other. That's not good, well vascularized ingrowth that's going to help bacterial clearance. And
Sure.
so if you're using it as a bridge in contaminated, I would say that's where I won't go.
Yeah. Okay. So how would you do this stepwise?
So stepwise, I think we'll get the sigmoid colectomy, take down the transverse colostomy, and then basically the I'm doing this as a partnered case with a colorectal surgeon. I'll have her tell me if she wants to do a loop ileostomy or not. If she's going to, then we'll pick out where we're going to do it, if we can use this transverse colostomy site that's on the right, or if we can reuse that or not. And then I'll get to work fixing things. And so this I'm not planning on getting into the retrorectus space for this. I'm going to try and basically create some skin flaps, lipocutaneous flaps.
Yeah.
I think that's an important part of being able to, you can see how in that third picture, the muscle tends to curl up at a hernia like this. And it's not until you release that edge, there's a lot of scar tissue along there usually from where the hernia has been pushing out. And you create a little bit of a lipocutaneous flap there. And that tends to be somewhat of a release for the hernia, for the muscle layers. And it gives you a little bit of extra room to work with.
Hmm.
And we'll try and bring it together. And if I can't, I'll use an absorbable mesh bridge to bridge this.
Okay. Great. I know on some of the next slides we have some
Oh
some
yeah,
kind of pictures to help kind of delineate because this anatomy always confuses me real
yeah,
time, especially when it's distorted with the ostomy being there, with the chronicity of the wound. So
right,
for those on the call, kind of we kind of show us exactly kind of where your dissection plan is going to be.
yeah. So I think some of these next pictures that I've got show like exposure of the retrorectus space, and then how to do transversus abdominis release as well as an external oblique release. I probably won't be doing those in this case, but if we had this very same case and there was no stomas and I was just going in to fix a hernia, this is what I'd do. So just a quick and apologies, I no art school for me, but I drew all these for a talk and labeled them on my own. So hopefully it looks okay.
This
This
is
would be
great.
this would be a standard abdominal wall. You see, you got the skin, subcutaneous tissue. Um, you got your lateral three layers: external oblique, internal oblique, transversus abdominis. You've got your anterior rectus fascia, your rectus abdominis muscle, your posterior rectus sheath, and then your peritoneum, that black line underneath. So when you're getting into the retrorectus space, really what you're doing is you lift up the medial aspect of the rectus complex and you try and find this medial aspect where the rectus muscle ends at the most medial space. You go in about a half centimeter or so lateral to that, and you incise the peritoneum and the posterior rectus sheath. And you do that for the entire length of that hernia defect.
Hmm.
And then you peel down the rectus sheath and the peritoneum extending laterally until you're out near the linea semilunaris. And what I have drawn there are some of these neurovascular bundles that are feeding the rectus muscle. When you get out lateral, you'll see probably like every maybe 3 centimeters or so, you'll see a bundle coming in laterally. That tells you you're out right near the linea semilunaris. You don't want to go any further than that. And you want to preserve those neurovascular bundles. If you take those, nothing will happen immediate post-op. But if you were to get a scan on that patient a year later, they wouldn't have a rectus muscle on that side. If you take those perforators, you'll see, you've seen a CT scan of somebody who's had a like a cholecystectomy via a right subcostal, and you look at that scan and there's no rectus muscle there. It's just totally it got denervated and it atrophied away. There might be some fatty replacement there. That's what happens if you take those neurovascular bundles. So at this point, after you've dissected this retrorectus space out on both sides, if you feel like you've got enough, you don't have to go any further. You can close this posterior sheath at the midline, lay your piece of mesh in the posterior rectus sheath, and then close the anterior sheath over top. And that's adequate for a lot of even big hernias. You can get just by doing this, and you don't have to do a myofascial release component separation further than this.
Okay.
Now, if you find that your anterior sheath is just way too far apart, you're not going to be able to bring it together, then your next step is to either do a transversus abdominis release or an external oblique release. And there's some advantages to each. So this depiction is how you would go about doing a transversus abdominis release. So what it may not show in Netter drawings is that the transversus abdominis muscle, it runs in the posterior rectus sheath, especially high in the abdomen, that upper third, from the xiphoid, down about maybe a third or a quarter of the way. It's really muscular up there, and you'll see it in the posterior sheath. So you'll have your posterior sheath dissected out. If you go and tap the cautery in the lateral posterior sheath, you'll see that contract, and that's your transversus abdominis. And so you find it in that upper abdomen. And what you can do is, you don't want to be right at the linea semilunaris. Otherwise, you can make a defect right through that whole space. You want to be about a centimeter and a half medial to that, away from those neurovascular bundles. And you can incise it like this. And what that does is it drops you into a preperitoneal plane. And this peritoneum, as you get out, especially quite lateral, it's pretty thick. And so you can start to peel it off the transversus abdominis, and you can get a nice wide plane. And so you've done two things really with this release. One is you've released the transversus abdominis, and it's given you a little bit more laxity to be able to pull that anterior sheath together. The second thing it's done is it's given you a really wide overlap region to put mesh, to put a really wide piece of mesh in that space. And that's shown here. So here what we've done is, after we did the transversus abdominis release, you can sew the posterior sheath together at the midline. That thick black line coming across the middle is the mesh, and you can see how you get it past the rectus muscle. So you get that nice wide overlap, and then you close up the anterior sheath there.
Okay.
The other option for a release, you shouldn't do both of these ever. One or the other. And you really just you can only cut this once. So this is a one-shot deal. The other is the external oblique release. And with that, you got to create a lipocutaneous flap all the way out past the linea semilunaris. And what you can do, you can see, then you cut the external oblique. You see out lateral where we cut it there. This actually gives you more release of the anterior sheath. You get a few more centimeters than you would with a transversus abdominis. The downside is what I have drawn there in this epic artistry here, which is the vascular supply to the skin and subcutaneous tissue. So you can get flap necrosis from creating a big lipocutaneous flap like that. So especially, you don't see a lot of skin die, but the subcu tissue can die off. And if it gets some bacteria in it, then they get a bad wound infection. You got to go in and debride all that. So this is much higher risk, essentially, of wound morbidity, wound infection, seroma, subcu hematoma, flap necrosis, all that stuff. A bit higher risk. Your benefit is that you get more release.
Yeah. Now, in this patient, before we move on to the next case,
Yeah,
um,
we can go back up here.
if you can just close this primarily, what are some tips and tricks to just closing this thing primarily? You said you don't think you're going to be able to, but if you can,
Yeah,
I mean, do you have a standard of suture you use? Do you have a
yeah,
standard bite technique you use? Knowing it's probably going to be under tissue, the skin's
yeah.
already compromised. How do you approach that if you, or even if you're just doing the primary repair before the mesh, but how exactly would you bring that fascia together if for some miracle you can get the edges close?
Yeah. So I think a couple of things. So one is that I'm a firm believer in the stitch trial.
Okay.
That being said, I'd never use a 2.0 PDS on a SH or a CT2 here.
Sure.
And you might say, how can now you're talking out of both sides of your mouth. Here's what I'd say. So, I mean, when you do these big hernia repairs, after people have had an open abdomen or multiple hernia repairs and you're chipping out mesh or they've had wound infections, that fascial edge is a rock. It
Sure.
is thick, it is firm, it is scar tissue. A lot of times you can excise a lot of that scar tissue, but you're looking at a fascial edge and you're like, I think this is the edge of it. I think I got all the scar tissue. I don't know for sure. When I'm looking at that, I'm thinking I need to take 1 centimeter bites to make sure I'm getting back on fascial tissue and 1 centimeter travel, and I'm using a number one PDS.
Okay. You
So
could be talked into Stratafix.
yes, yeah, I think I could. So I think and this gets into, there's decent literature showing that, if you do a running stitch, it's going to be have a lower rate of dehiscence than interrupteds. There's some decent literature, although Josh, I think your group just recently published one, Demoya, about doing interrupted and having better outcomes with interrupted. So it's not totally certain what's better, but here's what I'd say. If you're doing it either running or interrupted, the key is this. You can't tighten every stitch as you take it.
Sure.
You got to shoelace it. And that means if you're running it with a Stratafix or if you're running it with a non-barbed suture or if you're doing it with multiple interrupteds. It's placing a bunch of stitches, and then if you put all of that abdominal wall tension on one stitch as you take it and tighten it up, it's just going to saw right through.
Sure.
So you got to take multiple stitches there and then start to shoelace it together, meaning you try and tighten, 5 or 6 of them at a time and get that pulling together. And then I'll start at the top and I'll take a little tension off that way, shoelace those together, and then it starts to shimmy together a little bit. And so I don't know if it quite matters running, interrupted, barbed suture, non-barbed suture. I think this technique of shoelacing is what can be taking the tension off, not one suture at a time, but with multiple rows that you're trying to bring it together. Does that make
Sure.
sense?
Absolutely.
Yeah.
Absolutely. And before we go on to the next case, another question I think really bears worth answering now is you mentioned this absorbable mesh, and then you said one of the reasons is you may have to go back. How are the adhesions like from this mesh?
Yeah.
Does that come into
So,
play?
yeah, I think it does. Um, I think for any of you out there who have used biologic mesh, you could, you know that it's it's pretty uncertain what you're going to encounter. I've gone back on biologic mesh and it's just gone. There's nothing there. There's like maybe a layer of adhesion there. And then I've gone back on years later and there's a couple big chunks like stuck in areas and you're like, how is this not reabsorbing and dissolving? So with biologic mesh, not totally certain. Um, But with some of the absorbable meshes, we have a little bit better idea. Um, I've used some of the absorbable meshes, and I've gone back in laparoscopic, even though they had intraperitoneal placement and had um, lots of adhesions, but filmy.
Okay.
So the volume is high. There's stuff stuck, but it separates quite easily. And that CO2 then just tracks in there and you get a nice plane and you can just dissect that down without much difficulty. So um, the other sort of unknown factor is if I don't care what you use, if the patient gets a post-op wound infection or deep tissue space infection, the adhesions are going to suck. So it has nothing to do with the mesh that you've used. It's just like everything's going to be stuck because there was a post-op infection or a dehiscence or whatever the case may be. So I think we attribute some of the nastiness to the mesh when it really is the factor of the wound in the post-op period.
Sure. Well, thank you for that. Hopefully, I'm just glad I'm not seeing that in my clinic, but I'm probably the one handing it to you. You ready for another case?
Let's do it.
All right, let's move on to case number two. So naturally, we went through all of that. So this one should be a breeze. So this should be 57-year-old healthy woman, prior laparoscopic hand assist, right hemicolectomy. She does have a ventral hernia at the hand port extraction site. So far, pretty straightforward. And this is what you see. So I gotta ask, I mean, the robot's perfect for everyone, right? I mean, how would you approach this one? And walk us there's some key findings on the CT scan if you want to point out for nuance, but this
Yeah,
seems
yeah.
like a no-brainer compared to the previous one, right?
Well, yeah, we'll see, I guess. I think there's multiple good ways to fix this thing. I think the defect size here when I measured this on the CT scan is about 4.5 centimeters. And then there's a decent amount of hernia sac there as well.
Okay.
Um, and not much retraction of the abdominal wall. And it doesn't run the entire, what you can't see here is it doesn't run the entire length of the abdominal wall either. It's about 4.5 in all dimensions. Um, so in this one, I think how I would usually approach something like this is I'd do this as a robotic IPOM. Um, I like that I can close the fascia robotically. And then the IPOM, then I would sew in a piece of permanent mesh with an adhesion barrier on it for this. So now I probably, 10 years ago, I did these as a lap IPOM.
Okay.
This is one I wouldn't do anymore ever as a lap IPOM. And I think you could still get a good result, but when you've got 4.5 centimeters here, now you're talking about getting a pretty wide piece of mesh bridging and then a pretty big hernia sac that's left behind after that. And that's going to turn into a seroma um, without any sort. I mean, it might turn into a seroma even after closure, even after a robotic closure of it. But I think you reduce that rate compared to a laparoscopic IPOM here. sorry, IPOM, intraperitoneal onlay mesh, meaning a coated piece of mesh underneath all the muscle layers there. Intraperitoneal mesh. Yeah.
Now, there's a couple things that we can kind of game plan with this CT scan, and of course, us knowing that this patient is in your clinic means that there's something that's not straightforward. So we see some bowel that's really close to the subalma wall here, kind of on the screen left. Now, what if this was some type of inflammatory bowel disease, Crohn's, ulcerative colitis? We haven't gotten to an ostomy like we did the last case, but would that change your approach at all? Still doing robotic or changing it all?
For me it changes then.
Okay.
And I think, there's different gradations of Crohn's, but for sure, if they've got poorly controlled or history of fistulizing Crohn's, I'm I'm generally hesitant to put mesh intraperitoneal at that point. And it's not so much infection at the time, but if they have a fistulizing episode and then it goes to the mesh, it becomes a big deal at that point. Um, so I think at that point I'm more interested in keeping the mesh at least a layer or two away from the viscera and trying to put it in the retrorectus space. So for me, that would either be an ETEP, robotic ETEP, or an open retrorectus. And I think either one would be a reasonable approach to get into that retrorectus space and get the mesh there in this particular case.
So we went through the retrorectus kind of last time, or at least the beginning part of it, how you would do it. ETEP, how would you kind of briefly do that?
Yeah, so for the ETEP, what you're doing is you're getting your robotic trocars into the rectus sheath. You're in the you're behind the rectus muscle, just on top of the posterior rectus sheath. And what you can do is you bring a trocar in lateral and you try and get in that lateral aspect of go through the anterior sheath, go through the rectus muscle, and then drive it into that retrorectus space.
Yeah.
Inflate some CO2 gas, do a little camera dissection of that retrorectus space, and then you can get a couple more trocars in there. And then you can dock the robot, and what you can do then is come across medially, and you basically do a reverse um, retrorectus. So,
Okay.
meaning you're cutting the posterior rectus sheath, but you're cutting it from within the rectus sheath.
Sure.
In the rectus sheath, and you're cutting that posterior rectus sheath. Drop it into a preperitoneal plane, peel that hernia sac down, get over to the other side, and then the other side, you're doing it as a sort of traditional retrorectus. You're cutting the posterior rectus sheath at the most medial aspect and then getting lateral from there.
So you're doing this all from one side, crossing over the hernia defect,
That's
and
right.
at reverse on the entry, you cross over, then it's a little bit more normal on the contralateral side.
That's right. And that can keep you out of the abdomen
Okay.
and it keeps you in that retrorectus space where you can place mesh.
And you're doing that in this inflammatory because you just think that you wanted you want at least some additional tissue
Yeah.
coverage with that mesh.
Yeah.
And you're not trusting the peritoneal, you're not trusting the code, the omega-3 coating. You
That's right.
want muscle.
That's right.
Okay.
That's
Or at least fascia.
that's right.
Okay. So the other thing I notice on the CT scan is defect is really close to the skin. And sometimes we have these surgeries and the skin gets infected, it gets scarred, it gets irritated. We saw the last guy, he gets a skin graft. If she has this colon surgery and there's a wound infection with this thick scar that kind of is sometimes an issue, sometimes not an issue. It's close enough. Does that change? Is that still getting robot?
Probably not. I think if someone's got, they healed by secondary intent, they got that thick scar down the middle. It's that not very well vascularized midline. They got some tension on it. It ulcerates. That's the kind of thing that like that needs to be excised, bring good skin edges together. And if I'm going to excise a scar down the middle, then I'm going to do this as an open retrorectus. So the integrity to the skin and what you're going to do with the skin, I think helps dictate what approach I'm going to use too. So could you do that as a robotic repair and then finish the repair and then cut out the skin? I mean, you could, but damn, I guess if I'm making a big skin incision there and I'm in the hernia sac at that point, I would just do the whole thing open.
Okay.
Um,
Yeah, that makes a lot of sense.
yeah.
And I've got to ask because sometimes this comes up. We're all trying to do robot cases. We're all trying to adjust with the times. It, is every hernia, run-of-the-mill hernia, a robotic hernia? What
Yeah.
is the factor that a patient wouldn't get a robot approach in your hands?
So I think we could probably have a whole webinar on this, but my feeling is it's an awesome tool. Um, it's made a lot of cases so much more accessible to a minimally invasive approach. That being said, I think um, that robotic ventral hernia repairs um, have a higher rate you of sacrificing the transversus abdominis muscle.
Hmm.
So, meaning when I do an open retrorectus case, um, I can often get that posterior sheath together.
Okay.
And if I can't get the posterior sheath together, I don't do a tar. I
Sure.
do a tar for the anterior sheath where the real tension is, where the real meat of the closure is. I'll bridge that posterior sheath with vicryl mesh, hernia sac, whatever. I try and preserve the transversus abdominis if somebody doesn't need it taken. When you do a robotic retrorectus, I think even for smallish hernias, you kind of got to do a tar to get those together,
Okay.
or at a much higher rate than you would open.
Hmm.
And so I think there's some over utilization of the transversus abdominis release. You can only get one of those in your life, man.
Sure.
One in your life. So you burn that bridge. And so I try and preserve that. And that has shifted me back to doing some of these open in an effort to try and keep options open down the road, um, and not sacrifice muscle layers that we don't necessarily have to.
Great. Yeah, makes a lot of sense. All right. Well, then we tackled two cases. You want to do another one?
How we looking? Are we
We're
okay?
running out of time, but we can go a little bit more because there's this last case is the bane of my existence.
Okay, yeah. Let's talk peristomals quick.
So 45-year-old woman, again, we're running a theme here, ulcerative proctitis, total abdominal colectomy, gets the ileostomy. And of course, as always, there's a peristomal bulging and discomfort. Now, I'm sure at this point, just called me with ACS. Luckily, we got her through the night, but now the discomfort's progressively gotten worse. Now she's somehow seeing you. 3 pregnancies, rapid progression of peristomal bulging. Oh, she also has gone in APR, recovered well, and so now she's interested in discussing this peristomal hernia. The definitive operations are done. She just has this recurrent hernia and a lot of factors. What would we potentially do with this? This is the CT scan we show. This is not an uncommon CT scan in the acute care surgery world. It's not an uncommon CT scan in the general surgery one. It's just one that we hate seeing. So luckily
Totally,
you're here to help us
totally,
through. What are your
totally.
considerations here?
So I'd say the first is if you're seeing the patient in clinic or if you're ACS and this is more like a bowel obstruction situation, either case, the discussion is the same with the patient every time.
Okay,
This hernia has the worst outcomes of any hernia that we repair.
sure.
highest recurrence rate, highest wound morbidity rate, mesh infection rate, because you're doing these obviously when there's a stoma in place on 100% of people, right?
Sure.
So, so setting the tone that this this operation, there's high chances of recurrence and wound morbidity. And the way that I lay it out to patients that they understand is pretty simple. I tell them the best way to fix a hole in the muscle is to close it,
Sure.
right? It's the
Okay.
best way to fix it. If you have to leave a hole open and try and cinch it down to the right size in a dynamic, moving abdominal wall, the patients get that. They understand that makes it really difficult and complex to get a durable repair there.
Sure.
They're usually really upset at that point, hearing all that. And then I can go into, but we do have some repairs and that are options for this, and we can get a good, safe result in selected patients. So my approach to this, there's a ton of different ways you can do this. I tend to favor the sugar baker approach
Okay.
uh, as my go-to approach if I'm able to do it, and I do it laparoscopic or robotic. Um, Here's a little drawing of sugar
Hmm.
baker, and the reason I think this is important as, or this is why it's my go-to approach is there's two ways a peristomal can fail. One is if other organs, small bowel, other portions of colon, omentum, can go through that hole. This blocks the hole entirely.
Okay.
The other is that the bowel can act like an accordion and slink up there. And this, although not perfect, it can trap the bowel a little bit better than a keyhole might
Okay.
to keep it from sort of slinking up there like an accordion. And we'll just look at a friend of mine gave me this video. This is the downfall of a keyhole. I use keyholes when I have to, so don't think I'm not, I don't ever use one, but right there, see how that gets sucked up there? So this is
Wow.
the patient bucking
Okay.
um, as the guy's trying to reduce the peristomal hernia. He had pulled all that back in, and you can see how it can accordion up. And that hole is not small. It's not big.
Sure.
It's not a big hole, right? And stuff can still sneak up there. So this is sort of the downside of or can be the failure of a keyhole is a higher rate of that accordion sort of a deal. So I tend to favor the sugar baker approach, um, lap or robotic.
Okay. Now, should we just be putting the mesh routinely at the time of these ostomy prophylactically?
We don't.
Okay.
I think there's some conflicting literature out there about prophylactic mesh at the time of stoma,
Okay.
and I think it's pretty hotly debated still. There's a few studies showing that it reduces hernia rate, but now that we're seeing a bit longer term follow-up, especially in peristomals, um, there were lower rates at the 1 and 2 year mark, but they were equivalent at the 5 year mark. So just like a hernia repair is not 100% durable, neither is a prophylactic. I think there's a fair number of stomas that are made where you either know or have the idea that they might have a chance to have it taken down. And that's not one where you want to put mesh in at the time that you make the stoma. If there's any chance that that thing might come down at some point, I think you err on the side. And we know that having mesh in place at the time of an alternative operation increases complication rates.
Sure.
So, so if you can avoid that, if there's an inkling that they might get it taken down, other issues I think are the people who are making stomas aren't necessarily comfortable hernia experts getting mesh in the retrorectus space. And then reimbursement, payment for pretty expensive pieces of mesh that aren't necessarily um, you're not fixing a hernia. Why is it going in there? There's some reimbursement issues that might occur, both for the physician fee and some of the disposables there. Um, so I think the jury's still out on that. We're not currently doing it. I'm not currently an advocate for that.
Okay. That's good to know. I know mesh, and we can't have a hernia discussion without the risk of or talk of prophylactic mesh. The other
Yeah.
thing is for these laparotomies, we talked about two procedures that had some variation of a laparotomy, hand assist or midline. Should I just go ahead and be putting prophylactic mesh at the time of those midline laparotomy closures in emergency general surgery?
Yeah, I think another area of controversy. I right now fall on the side of no,
Okay.
for a couple of reasons. One is, um, most of the literature will tell us 15-ish% rate of hernia
Sure.
after a laparotomy. Um, that means you're going to put mesh into 85% of people, maybe violate their retrorectus space. Um, any mesh related complications there, kind of tough to justify, because most of the people who are going to have complications never would have needed mesh to begin with, right? A little
Absolutely.
different for peristomals. The debate on peristomals is different because just about everybody with a stoma gets a peristomal hernia, right? But but not everybody with a laparotomy does.
Sure.
So I think you're subjecting a lot of people to the downsides of mesh, 85% who
Sure.
would never have needed it.
That's an excellent point. Well, thank you so much. We've got one other question from the audience that I think is a phenomenal one. So we'd love to get your opinion on this. Do you have any tips for doing that tar dissection up closer to the diaphragm? You said it was pretty muscular up there anyway, but
Yeah, yeah,
how can you avoid getting to that pleural space,
yeah,
especially
yeah,
when you're
yeah.
high up?
Yeah, so when you've got a subxiphoid hernia, then I mean, I actually kind of like getting the tar up there. You got to make sure you're dropping into the preperitoneal space because if you drop preperitoneal, you'll be able to peel that peritoneum down and get right under the xiphoid and get some overlap up there. And there is an extra layer that is more distinguishable up there, um, that you have to enter right before you get to the transversus. So there's a um, posterior lamella of the internal oblique, and it'll be pretty thick there. You'll go through that, then you'll see those muscle fibers of the transversus abdominis. You take those, and if you're right up near near the xiphoid, you'll be able to then see and feel the transversus abdominis, or the transversalis. It's a little thicker up there, and you'll have one more layer to go to get preperitoneal. You got to go through that transversalis fascia. When you're preperitoneal, you're not going to get into the chest, the pleura, any of that. You'll get right into that zone that you need, and you can connect the two sides to be able to get that nice high overlap. It's a pretty, I mean, I've gone all the way through the peritoneum trying to get through that at times. It's a pretty subtle, it's real strong, but it's very thin, that transversalis fascia plane up high. Um, but if you can just gently get through that, then you're going to be able to stay preperitoneal, get across, and then get that down. It's
Well,
a great
that's great.
question. I wish I had a video to show you.
Yeah.
I mean, that gets really technical, but it's a really tough problem when you're up high. And it takes just, a little bit of, figuring out some of those layers.
Well, this has been phenomenal. Now, before I let you go, I got to know these are complex cases. So, one, who controls the music? And then if you're doing this case, what is your go-to playlist for knocking out these complex, especially robotic cases?
Sure. So I would say I used to always control the
Okay,
music, but now sometimes the technician, I need to keep the technician engaged
sure.
in honestly in these complex ab wall, I'm not asking for a lot of instruments. It's a DeBakey, some Cokers, some Leahys, and the Bovie, and some Alice's. So the technician gets a little bored. I got to keep him or her engaged. So I let them pick the music. If I do get to pick it, though, I've got a mix. I try and shuffle it up a bit. We've got it's got current pop. It's got old school rap. It's got some oldies, some classic rock. It's got some indie rock. I try and keep it mixed up so that people can't complain about too much because the
That's
next song will be a little different.
it's quite the eclectic mix.
Yeah, yeah.
All
Stop
right.
by. Oh, you can listen.
I should. Well, thanks so much. I see
Yeah, you
Dr.
bet.
Contag on board for us from the associate fellow, so we'll have her take it away. Thank you so much, Dr. Kastenmeier. We appreciate it.
All
Thanks,
right,
John.
thank you. This was an incredible session today. And for those who may have had to step away like I did for some clinical duties during it, it will be online on the RAS website for review later. For anyone who's interested, if you're not currently a resident associate fellow member of the American College of Surgeons, we have dropped a link in the chat. Please feel free to peruse that link, sign up for any committees you feel excited about joining, sign up for RAS in general if you aren't yet currently a member. This is a product of the Associate Fellow Committee. So if you're no longer a resident, but not yet a formal fellow of the College of Surgeons, but maybe a clinical fellow out there in the world or early in your career practice, this committee and the content we've created is for you, and you're welcome to join our committee and give us more ideas. If you're still a resident or a student in training, please join RAF and get involved with their committees to help us put on more educational content like this. And beyond that, we'll look forward to next webinar in April. We haven't set the date yet, but we'll email it out as soon as we do. The topic is going to be considerations and management of the open abdomen. So if you don't know what taut bars are, or you want to learn more about direct peritoneal resuscitation, this will be a talk for you. Thank you all for attending.